VMR. Again, hi everyone. Welcome to another VMR. Today we'll discuss with Ravi, and we are excited. So if anyone has a case that want to present, please tell us. How are you, Ravi?
I'm doing very well. Deborah will tell you, I've been waiting for this moment for a long time. I would gently message her on WhatsApp. So, hey, when are we going to discuss together? And she would be like, when the time is right, when the time is right. And for those of you who may or may not know Deborah, she does an incredible amount of things just for the CP solvers alone, let alone her actual full life. She is behind many of the illustrations that you see on Twitter and on the podcast. She is a fearless leader of VMR. You'll notice that whenever we're behind on VMR and scribing, that you'll see the name Deborah just pop up randomly out of the blue in the middle of scribing and teaching. She's ferocious in her scribing and typing abilities. And she's involved in so many of our intermittent events that you see pop up here and there. So it's always a thrill to be able to spend a little bit of time, take a moment to discuss some medicine with people who are doing incredible things. So as more and more people join, I was going to say that it's always so nice and rare to have a intimate small group, but I think the numbers are slowly but surely rising. And so, as always, we'll lean on you, any of you, if you have a case to present. So if you have a case to present, please let us know and type it in the chat. Look forward to it. Deborah, I think people are too intimidated to present a case to you, too scared.
No, please don't.
Hi, Arush. Hi, Amanda. Thank you for turning your videos on. So nice to see you. Long time no see, Amanda. How are you?
Yes, long time, Robin. I'm fine. Life crazy in medical school, but I'm back and I'm happy to be back.
It's so good to have you. So good to have you. Arush, how are you? You're doing well. Wonderful. Wonderful. I'm so glad to see that. All right, maybe we can lean on Ravi, as always, to bail us out and tell us about a case that he knows about. How does that sound, Ravi?
Sounds great. Yeah.
Right.
Let's get started. So, so today's case, we have a 76-year-old gentleman who came in from his primary care physician's office due to having altered mental status that was started about 10 days prior. Initially, he was taken to the primary care physician's office. He was confused, disoriented, and this was associated with speech, and he was also having some mobility difficulties. His wife also said he had urinary incontinence, and about 10 days prior, he was fully functional, was at a charity event, was at his baseline until this happened. And I'll stop there. Yeah.
What do you think, Deborah?
So it's an old man with AMS. So I think we always think about our mnemonic mist that is metabolic, that could be something, the glucose, the sodium, or the calcium. We think about an infection, something structural, a toxin. But make me like scared because he's been like that for a while. So that is the kind of patient that we need to take care and see to take care of his mental functions too. Like, I don't know, maybe like depending on how he looks at, intubated him to make him to preserve his neurologic function. And then let me see, he presented with confusion, mobility. Maybe he had like a seizure, like because of the urinary incontinence, mobility difficulties. We have to know for how long time was that. And before that, he was pretty functional. So that is strange because that 10 days before he had nothing. Now he's trying to present like this. I would be worried and try to investigate it more, know past medical history, meds, and yeah, I think that's where I would start.
Amazing. I think you taught us a lot. Whenever you hear altered mental status, you use the mnemonic MIST, metabolic infection structural toxin. You also taught us how important it is sometimes to treat before diagnosis with maybe intubating a patient who is very, very confused for airway protection. And then you also taught us something really important, which is when you have urinary issues in somebody who's confused, you should strongly consider the possibility of seizure. And there's so much teaching there with such little time. What will I do? I'll just say to give you a parallel view of altered mental status. In parallel with Deborah, one question that we're asking is the problem in the brain, or is this a systemic cause that's causing the brain to not work? In other words, is this an intrinsic problem in the brain, or is this extrinsic? A good example of intrinsic is meningitis. A good example of extrinsic is hyponatremia causing altered mental status. Intrinsic causes are way more dangerous and way more morbid and less reversible. So extrinsic are more common, but intrinsic are more deadly. So in parallel to working up metabolic infection toxin, you have to think, is there clues that this is intrinsic? And I think the answer is yes. Why? Deborah already said that their urinary incontinence is a clue that the patient might have seizure. I also heard Ravi say he's having speech difficulties, which is very concerning for an intrinsic problem. And also that the patient used to be so normal and now is this confused. The degree of encephalopathy is also concerning for an intrinsic brain problem. So how is the approach to intrinsic brain problem different than altered mental status? It's different, right? Altered mental status, intrinsic plus extrinsic. What if you build a schema for intrinsic AMS? And just like MIST, M-I-S-T, there's also 4 causes of intrinsic altered mental status: parenchyma, vessels, ventricles, and meninges. Parenchyma, like a tumor; vessels, like a stroke; ventricles, hydrocephalus; and meninges, meningitis. So in this patient, I think we need to listen to Deborah and work up MIST. And I also think we need to listen to Deborah because she said seizure, to also prioritize an intrinsic problem in those 4 categories. And I am, like you, Deborah, very worried about this patient because the probability of an intrinsic cause is very high. Many people with altered mental status, you're not worried. You're like, well, UTI, maybe medication, we'll fix it, no problem. We're very worried that we may not be able to quickly fix this problem. All right, Ravi, back to you.
Okay, moving on to past medical history: hypertension, hyperlipidemia, and anxiety disorder. Social history: occasional alcohol, medical marijuana. Family history: hypertension. Medications: oxycodone, aspirin, acetaminophen, atorvastatin, clopidogrel, Flomax, and Nexium. No allergies. And then vital signs: no fever, heart rate 124, blood pressure 200/115, respiratory rate 16, oxygen saturation 96% on room air. And the exam, so restless in bed. And the significant exam was the neurology exam. We'll just skip to that. Confused, is able to follow simple commands but needs redirection. No dysarthria or aphasia, but has incoherent speech and incomprehensible sentences. Cranial nerves intact. We weren't able to examine gait due to his irritability and anxiety and non-cooperation. And I guess muscle strength was diminished in all extremities, about 4 out of 5. And that's about it. We'll stop here for this aliquot.
Okay, so we have a lot of information here. So starting for the hypertension, the patient is hypertensive now, so make me think if the patient is taking care of the hypertension, if the patient is taking the medication, because it's one of the first things that a patient can present with for hypertension in the hospital can be not taking the medication well. I had to Google it. I didn't know what oxycodone is, but I don't know. And then I discovered it's an opioid. I'm asking why he's taking this medication. That makes me want to know more. Let me see. Yeah, the anxious, if he's taking care of that. And going for, let me see something else here in the past medical history. And then, yeah, the rumor 96% has to, continue to take a look at him, and he's confused and able to talk. So nothing. I think I would be worried about this patient, and it's the kind of patient that we have to be in bad side. So, and the neuro exam, I'm thinking what could be. Maybe I need to do more tests to see how is the glucose, how is the, yeah, I think that's where I would start.
You thinking of glucose is really important because hypoglycemia can cause tachycardia and hypertension. So it's really important to think about it here. Deborah, are you surprised by how confused he is? Remember, this guy 10 days ago was normal. It's pretty deep, this confusion, and I completely agree with you. There's a couple of inconsistencies. One, you don't know why he's on oxycodone, and maybe he's having opiate withdrawal, not taking oxycodone, causing tachycardia and hypertension. But that doesn't usually cause altered mental status, right? And I think the other thing to think about is when you have tachycardia and hypertension, is he in pain? And maybe he can't tell us he's in pain because he's confused. And one common cause is urinary retention. So Flomax is a medication for BPH, and he may have urinary retention from Flomax, causing tachycardia, hypertension, and confusion. So I think, Deborah, the question for you is, if you were taking care of him in real life, you're going to get labs. Would you think you want CT scan in him, or how would you get a CT scan now, or would you wait for the labs, or how would you take care of him in real life if you were the doctor right now? What do you think?
I would take now.
Yeah,
I would take the blood for the labs and take for the patient for the CT.
yeah, I completely agree with you. He's too confused to just say, oh, the answer is going to be in the labs. He's too sick. And tachycardia, hypertension, and confusion can easily be from a stroke or a bleed. Now, the harder question for you, my friend. Labs normal, CT normal. Would you get MRI today? What do you think?
I'm thinking first, if I was in Brazil, I would not have a possibility to get an MRI so fast. But if I have the possibility, yes, I would get.
I think that this patient, you really have to say, you need an answer, you know, and especially somebody who's so sick. So I agree with you. I think the labs we should get and the CT scan will be helpful. The tachycardia and hypertension make me worry that urinary retention may be here, and we can talk later about if he has urinary retention, how that can cause confusion. There are many ways, but also hoping and worrying that maybe he has a toxin like opiate withdrawal, alcohol withdrawal, uh, anticholinergic toxicity. Those are things we should think about. But let's see what the labs show. But this patient probably needs advanced imaging to get to the bottom of it. All right, Ravi, back to you. Oh, I think you're muted, my friend.
Yeah, I added the labs to the chat. Thank you. Yeah. The labs were pretty much normal. Normal white count, 9.36, hemoglobin 15, platelet 272, chem was normal. Just to cut to the chase, urine analysis was normal. COVID was normal. There was a head CT done showing no evidence of acute intracranial pathology, diffuse involutional changes, and some chronic ischemic small vessel disease changes. And then an X-ray also was normal. And I'll just add to this, since stroke was being mentioned, an EEG, which was done early in the course, showed some excess of slow theta activity along with some bifrontal, very slow delta activity, non-specific findings suggesting presence of mild diffuse disturbance in cerebral function, but no suggestion of epileptiform activity. And I will stop right there for discussion.
Ravi's giving you such a hard case. So confused, normal labs, no clue, good luck. What are you thinking now?
Nothing. We didn't get too much answers here. Oh, yeah, page neuro.
Yeah, right?
I think a toxin test.
Yeah.
We should do it, and yeah, maybe an MRI.
Yeah.
So yeah, but everything is not like,
Yeah, everything is normal.
I don't know. I think I would rather toxins,
Yeah.
do an MRI, and
Beautiful.
that's where I would start.
Beautiful. Any toxins, just to practice the teaching, any toxins that you are most worried about in this situation that you would make sure you collect?
I am worried about the opioids. I don't know why his patient is taking the opioids.
Beautiful. Yeah.
Yeah.
Any other toxins that you think cause tachycardia, hypertension, altered mental status?
Good question.
Yeah.
I don't know if someone said cocaine in the chat.
Yeah.
Thank you. Yeah, maybe that, but being honest, I don't remember right now.
Yeah, I think the reason you're not jumping to them, they're possible. The reason you're not jumping to them, and I agree with them, it's unusual to be that confused, this confused. You know, like you probably have seen some patients on cocaine or amphetamine. They're not coma, you know? So I think the reason it's a little bit unusual and you're not thinking of them because they don't match perfect. Somebody who is confused from cocaine and amphetamines usually has an agitated confusion, not that he is sitting there not able to listen to you. So it's a little weird. So I agree with you. I think the toxins should be ruled out, but I don't think any toxins make perfect sense here. So I think the question for us is we probably definitely need an MRI. What do you think might show up on MRI?
No, Robbie just said that it's normal. MRI intoxicating is normal.
Oh,
So
I didn't see
I
that.
think
Yeah, I was just trying to, for the sake of time, just giving you some more data. So MRI normal, urine tox screen normal. Any additional tests you would like, Deborah?
I would start again. I would start thinking from the beginning. I think, yeah, maybe the urinary retention. We could try an ultrasound maybe. I don't know. I would start again to see what this patient has been doing. How was he the 10 days before? What he was fully function? What are you meaning at fully function? He was taking all this medication well or not? Yeah, when he Nikita said when he was his last drunk.
I'm right there with you, Deborah, for the sake of time. I think if you really could do one test right now, it would be ultrasound of the bladder. What else causes such degree of altered mental status with normal MRI? And the diagnosis that urinary retention causes this degree of confusion, I learned from Ravi and Travis. It's called cystocerebral syndrome. So I think it would be really, really important to get a bladder ultrasound. And I think it's perfect that that would be the next diagnostic test for our POCUSed presenter, Ravi, and our most passionate POCUSed VMR member, Deborah. So I think that would be really cool. So if bladder scan is negative, I quit, I give up. I don't know anything that this patient has. But I want to emphasize in 10 seconds what you did. It doesn't matter what this patient has. Everyone who's listening on YouTube and here watched what a really smart doctor would do. If the MRI is normal in a patient with confusion, go back. Go back. Don't go forward. Don't keep brain biopsy, LP. No. Go back. And Deborah, the most important thing you taught us today is that when you have an unexpected result, don't go forward. Reanalyze what you already have. Amazing job. All right, Ravi, either I'm fired or this is a POCUS case for Deborah. Tell us which one.
Okay, so yeah, there unfortunately nothing wrong with the bladder. Patient continued to exhibit this delirium encephalopathy and requiring restraints. And so everybody's puzzled, what is going on? And neurology, as correctly somebody asked, well, let's get neurology on board after exhausting all possible potential causes and going through the missed mnemonic 3 or 4 times. Let's go ahead and do an LP. So an LP was done, I think Max had mentioned, and the LP showed protein of 120, glucose 66, it was hazy, absent xanthochromia, white cells, surprisingly, 1592, SEGs 13, lymphocytes 80, and the microbiology molecular testing, negative for Cryptococcus, negative for CMV, negative for enterovirus, E. coli, negative for HSV1, but positive for HSV2. And I'll stop there for reflections.
Well, Deborah, I've just been fired, so only you are left now. What do you think?
Yeah, HSV1 can cause encephalopathy, no, encephalitis, and HSV2 can cause meningitis. But I think maybe could be, no, an acute encephalitis from HSV2. And yeah, I don't know.
Yeah, I think Deborah, I agree with you. I think is it possible? I think what in our thinking, we said it's probably inside the brain. And we said, is it parenchyma, vessels, ventricles, and meninges, right? We looked at the parenchyma with MRI. We looked at the vessels, no stroke. We looked at the ventricles, no hydrocephalus. And the final thing is it meninges? And I think it's surprising that the meninges didn't come in with neck stiffness and didn't come in with fever and all sorts of things, but it's not unheard of. And I think this is a great reminder of how easily you can be fooled by encephalitis. Yeah. Have you heard of HSV encephalitis before?
I think I had most associated with meningitis. Am I wrong? I always think that one is E that comes first, that encephalitis, and two that comes with M, that is meningitis. But I think in cows too. No, it's
Yeah, maybe Ravi can teach us.
yeah.
Oh, sure. I was dropping some of the teaching points in the chat, but I mentioned there HSV1. HSV1 is usually more commonly the cause of encephalitis, but this was very unusual for HSV2. Usually found in neonatal and rarely in adults, so this was a rare case. But as we all know, HSV1 can present with fever, seizures, altermental status, as in this case, and focal neurological deficits, and you can get this unilateral temporal lobe edema, hemorrhage, or enhancement. Sometimes the MRI can help you focus in on that. And with the CSF here, you should see that lymphocytic pleocytosis is in the CPS schema for pleocytosis. And you also get an elevated protein level, normal glucose. So this would suggest a viral cause of this infection. EEG sometimes can help identify the degree of cerebral dysfunction, and specifically in the temporal lobe with HSV. So it can help, but if it's normal EEG, doesn't necessarily rule that out. And years ago, sometimes they would do brain biopsies, but not necessary. But we have good microbiological testing nowadays, PCR and so on. And empiric therapy, acyclovir, was given to this patient, and it did help in this case. And so case of HSV encephalitis, but particularly HSV1. Great job, Deborah.
Amazing.
Thank you.
How did that feel?
Feels good.
Nervous, huh?
Thank you, Ravi, for the case. Ravi sent me a message excited for that I was discussing. So nothing. It's good to have good friends and mentors that support you. And nothing. It was really good, and I really appreciate the opportunity.
What do you think was harder than you thought it was going to be?
I think I was gonna be nervous and don't remember anything.
What do you think you did well?
What?
What do you think you did well?
I think I breathed. I didn't get so nervous.
Yeah.
I let my mind thought and nothing. I think it was great.
Yeah, I completely agree. I think that you did such an authentic discussion and conversation, and you taught us MIST, you taught us urinary retention, seizure, you taught us that a sick patient with brain issues should get an MRI. And I learned my growth point was MRI negative brain disease, get an LP. I think that's the key thing. And that was a really nice way to learn this. But hopefully somebody will rehire me after I just publicly told myself to be fired. So we'll see. Thank you, Ravi, for an incredibly educational case as always. And Deborah, our first ever discussion, I thoroughly enjoyed it. And I agree. I think you were absolutely awesome, as everyone in the chat is saying. All right, Ariel, take us home, please.
All right, what a great case. Thank you so much for the case presenter and for Deborah and Ravi's wonderful discussion. So we talked about altered mental status, and we first think about the misdemonic, which represents, which is metabolic, infection, structural, and toxin causes. So that mnemonic includes both intrinsic, which is in the brain, and extrinsic causes of altered mental status. The extrinsic one causes are more common, but intrinsic ones are more deadly. So it is very important for us to have a taste earlier of which one we are possibly be leaning towards. So this case, we have some red flags of neurologic deficits like urinary incontinence and confusion that made us suspicious of an intrinsic cause from the very start. Ravi reminds us that we should start treatment before diagnosis in certain cases if we're worried about airway, for example. And then for intrinsic altered mental status, we think about the brain parenchyma, vessels, ventricle, and meninges. We talk about different mode of diagnosis. CT, MRI will probably be needed at the start for cases that we're worried about intrinsic causes, but we always want labs and sometimes toxin screening. And we also briefly talked about how urinary retention can cause pain and confusion, the cystocerebral syndrome, which, yeah, I remember from a previous discussion. But turns out our patients doesn't have that. Our patient has negative CT, normal labs, and negative MRI, negative EEG, like everything was normal. But then CSF revealed the final diagnosis of HSV encephalitis. So HSV1 is more common. Our patient has HSV2. The common presentation is fever, seizures, altered mental status, or neural deficits. CSF PCR is the gold standard, but false negative is possible. So repeat that if we are highly suspicious that the patient may have it. MRI of temporal lobe involvement supports the diagnosis, but negative MRI doesn't alter the decision of empiric treatment. CSF lymphocytic pleocytosis, elevated protein, and normal glucose suggests a viral infection. EEG can help diagnose, but again, the negative ones doesn't rule it out. And then our patient receives antiviral therapy. That's all I get.
Amazing. Oh, that's all you got. That was absolutely superb. A great walkthrough through the entire journey. Thank you so much for all those pearls. And I know Ravi had to leave, but thank you to him for presenting. And Deborah, I hope we do this hundreds and hundreds of times. I look forward to the next time. Thank you all for joining. Bye.